wasn't conventional. Because I've been to numerous conferences and lectures, and everyone's first slide is always very similar. It has a background design or pattern, and then it has the title of the presentation, even though it's just right there in the agenda and the moderator literally just mentioned it. In addition, it always has the name of the presenter, a few fancy titles, just to hype himself up, and also quite a few logos, which can even make the Formula One driver's uniform blush. And finally, it may have an image. In my case, it's the CN Tower, which is iconic of the city I'm from, Toronto. So I guess what the presenter is trying to do here is establishing their identity. Now, identity is an interesting concept. It is the unique way that you define yourself. It's the fundamental answer to the age-old question, who am I? Now, the question, who am I, is a fundamental and philosophical one that has been contemplated by humans for centuries. So the answer to who am I is complex and highly individualistic, but at least in the professional and academic sense, who am I is much easier to answer. Right? I'm a radiologist. We are radiologists. So we have that commonality. We have a bond that binds us. But that seemingly innocuous question can become really tricky when it is posed by someone outside medicine. For example, on my flight from Toronto to London, I was seated beside this delightful elderly woman with a very British accent. So we got about chatting, and inevitably, she poses the question, who I am. I'm a radiologist, I answer. And without missing a beat, she goes, what's a radiologist? And that had me stumped. How do I define who I am? How do I define what a radiologist is? Well, the Oxford Dictionary defines radiologist as a person employing ionizing radiation or radioactive material in any field. That's misleading. And both the Oxford and the Merriam-Webster Dictionary define radiologist as a physician specializing in radiology. Well, that isn't very helpful. Looks like the age of dictionaries is over. This is the age of ChatGPT, which has taken the world by storm. So let's see if it is any more useful. Well, ChatGPT define radiologist. Medical doctors, medical imaging, health medical professionals, yada, yada, yada. It's more elaborate, yes, but it doesn't capture the essence of what being a radiologist is to explain to a layperson. So, what's the simplest way to explain what a radiologist is? What a radiologist does? To my friendly British neighbor on this flight, I wonder, what is it that we do? Well, for example, here is a CT, and within a fraction of a second, most of us have identified this nodule. Aha! So I tell my neighbor, we detect diseases. We identify diseases on pictures. And I felt really happy with that explanation. But with a thoughtful look on her face, she says, that difficult? With an incredulous tone. So I immediately realized that this explanation, it doesn't convey the complexity involved. So after a bit of thought, I said, well, you see, the diseases they like to hide and are quite tricky to find. And with a booming laughter, she goes, oh, so you're the best in the world at hide and seek. That's an interesting thought. Radiologists are the best at hide and seek, if only it were an Olympic sport. Interestingly, a recent promotional campaign by radiologists from Alberta, which is one of the provinces in Canada, highlighted exactly this. This was a promotional campaign to raise public awareness on the vital role of radiologists. Have a look yourself. So I showed my British neighbor this, and she was rightfully amused. Then I had a brainwave. It's not exactly like hide and seek, I said. It's more like playing Where's Waldo. Now, in Where's Waldo, we are searching for this visual character, this guy who has like red and white striped shirts with his rounded glasses. We're trying to find him within a crowded visual scene. In radiology, we are searching for diseases in the midst of crowded organs. Visual search, pattern recognition, and attention to detail are key components of both. Her face lit up with a spark of comprehension. Bingo, I thought. I had hit the jackpot. But in typical British fashion, she had to have the last word. It's not Where's Waldo's, she said, it's Where's Wally. So apparently, it was originally called Wally by the British creator and illustrator Martin Harnford, and the moniker changed when he hopped across the pond to North America and Wally became Waldo. Why? Because the publishers thought it was better. But while she was explaining this to me, I was wondering, are radiologists actually good at Where's Waldo? Because I couldn't find Waldo in that picture I showed you. So, does radiology skills actually translate detection in the real world? Is that the superpower of the radiologist? Because I would love it if it was my superpower. Every time my girlfriend lost her keys, it would be me, the radiologist, to the rescue. I would swoop in and use my amazing detection skills to locate her apartment keys every time. But unfortunately, that doesn't seem to occur. I am as bad as anybody else in locating stuff in my messy flat. In fact, a recent study in academic radiology showed that practicing Where's Waldo does not actually facilitate detection skills. So while these thoughts were going on in my mind, my friendly British neighbor turned to me and with a beaming smile said, "You must be very proud." And that gave me pause again. Because pride, like identity, is another confusing concept. Yes, I am a radiologist. Yes, I try to do my job to the best of my ability. But what exactly am I proud of? What character of mine elevates me to feel proud of myself? When should a radiologist really feel proud of themselves? So it is with these perplexing thoughts which has confused me for quite a while. Well, you know what? Let's explore a few cases, and hopefully by the end of the session, we get further clarity on all of this. Right? With that, let's begin with case one, the first of our 8 unsolved cases from the archives. Now, this is a quick QR code, but you probably don't need that. You can use the link which was provided to you, but I'll be showing the cases here anyways, right? So have a look at the case. I'm going to give you a couple of minutes. And by the way, the patient has a history of recently detected lung cancer. All right, that's enough time. So let's look back here. When you looked at the case, most of us have search patterns, and you probably noticed a few abnormalities. You may have been wondering about what they are, and you were running through the differentials. But as soon as I mentioned the history of lung cancer, you notice how the complexion of the case changed immediately. Now, let's see what you were able to find. I just put it in the chat here. How many of you identified the left adrenal metastasis? Yep, perfect. How many of you identified the smaller right adrenal metastasis? How many of you identified this bone metastasis in the pelvis? Yeah, quite a few of you. But how about this really subtle liver metastasis? How many of you were able to identify the bilateral small renal metastasis? Okay, what about the small pancreatic metastasis? And finally, here's the kicker. How many of you identified this right common iliac vein thrombosis? Now, thrombosis is often found with worsening cancers due to hypercoagulability. This thrombus can detach and result in pulmonary embolism and often results in a bad outcome more than the metastases themselves. Now, thus, we find that having a history of lung cancer not only changes the interpretation of what we find, but also should ideally lead to a targeted search for other possible abnormalities in this setting, especially abnormalities which can affect the outcome of the patient. Now, finally, how many of you identified this bony metastasis in the left femur? Because subsequently, this is what resulted in a pathologic fracture of the left femur within the following month. While this was fixed by ortho, unfortunately, he developed infection and abscess and ultimately succumbed to sepsis. The patient did not die from lung cancer, but rather due to sepsis after fixation of a pathologic fracture secondary to a femoral neck metastasis. So, what's the moral of the story here? Is the moral that routine search pattern should be very meticulous and involve each and every organ in each and every case? Maybe. Maybe that is the moral. Wait, wait a minute. What's happening? What's the interruption? What? Who is this? I've never been interrupted in any other lecture before, and I didn't think I would be interrupted today. Who are you, and what do you mean you see but you do not observe? Kind of seems like something Master Yoda would say in the Star Wars franchise. The distinction is clear. What are you talking about? What do you mean see and observe? You know? Let's ask ChatGPT. Hey, ChatGPT, what is the difference between see and observe? See is more casual and automatic. Observe is a deliberate and a focused act. It involves both vision as well as thought. That's interesting. Hmm. For example, we immediately see the nodule, but let's look at the video here. Now, count the number of times players wearing white pass the ball. Well, the correct answer, of course, is 16 passes. But did you spot the gorilla? Let's have a look again. And that was the gorilla right there in the middle. Similarly, even in this chess CT, which I had shown twice previously, there is a gorilla right here. It's very easy to miss if you're not looking for it. Okay. So let's go back to the previous video. Uh, how many of you identified the gorilla? Well, some of you did. So did you spot the gorilla? Probably yes. So for people who haven't seen or heard about it, half the people would miss the gorilla. But if you knew about the gorilla, you probably saw it. But did you notice that the curtain changed color and one player of the black team actually left the game? Starts from being red curtains It ends up being orange. We started with 3 white and 3 black layers, and we end up with only 3 white and 2 black layers. The moral of the case is that it's not that we need extensive routine search patterns, because most of us approach every single case the exact same way. If you're looking for a gorilla, you will find the gorilla. But if you're not looking for other things, if you're not looking for other unexpected events, you're not going to find it. So the thought that a search pattern is important, a search pattern which is routine, would imply that we are just seeing, which is passive, casual, and automatic, which is not enough. What we need to do is observe by combining thought with vision. So we see in the above examples that we only find what we are looking for. So we need to know what we need to look for in each and every clinical scenario. What we need is not search patterns, but thought patterns in every given clinical scenario. So for example, in lung cancer, these are the sites to look or search for diseases. Also, instead of spending the same amount of time on each and every organ in each and every case, we need to be able to dramatically and dynamically modify the amount of time we spend and how meticulous we search in each organ, depending on the pretest probability of finding an abnormality in that organ in that given clinical scenario. For example, if this is lung cancer, these are the places where we need to search. However, in a patient with ovarian cancer, the likelihood of renal metastasis is extremely low, and peritoneal metastasis is very, very high. So we need to spend more time on the peritoneum and less time on the kidney. And that is how to observe and not just see. Right? Perfect. With that, let's move to case number 2. So there wasn't a case given for this because this is pretty quick. Have a look at this. I'll give you 15 seconds. I want you to just concentrate on the bilateral groin areas. Just this. So, what do you think this is? Just bilateral fat-containing inguinal hernias, right? In addition, we also find that there is some surgery in the left groin. So it's prior hernia repair. So at least on the left side, it has to be a recurrent hernia, right? So let's take a step back. What's the definition of an inguinal hernia? It's herniation of abdominal contents, either bowel or omental fat, through a peritoneal sac. Okay? All right. Wait. Oh my God. A random anonymous stranger strikes again with his condescending quotes. The world is full of obvious things which nobody by chance ever observes. What obvious thing that we did not observe? Let's have a look at it again. Where does this fat come from? Let's trace this and this. Let's trace it on the right side because it's easier. So let's just trace this. And this fat comes here, 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 and from here, it actually comes from the retroperitoneum. It's not coming from the peritoneum into the peritoneal sac. Both of this comes from the retroperitoneum, and it is sliding into the inguinal canal bilaterally here. So you aren't very convinced? Let's have a look at a different companion case. All right. Once again, there is a right groin hernia. In this case, have a look here. Once again, there is fat on the right side. Okay. On the coronal, it's actually much more clearer. It's arising from the retroperitoneum. And in fact, it's even pulling the kidney down, as you can see. So this has been variably called as sliding hernia, or more often spermatic cord lipoma, which is obviously a misnomer. But the question is, why is this distinction between retroperitoneal and inguinal hernia even important? The patient would still have clinical features of hernia, right? But that's exactly the point. The patient would present with inguinal hernia and will be treated like an inguinal hernia, which may be inadequate. The most common surgery for hernia these days is endoscopic, TAP or TEP, transabdominal preperitoneal versus total extraperitoneal. In both of these, such a retroperitoneal hernia can be missed although it's more likely to be missed on tap. So the major societies recommend an active search for this type of hernia in all laparoendoscopic hernia repairs. It is so unfortunate because in the first patient, they thought it was an inguinal hernia. They fixed an inguinal hernia, whereas it was not an inguinal hernia, it was always a retroperitoneal fat. And it is so unfortunate that just because radiologists have never bothered to be vigilant of this, we have never bothered to make this distinction, we have never bothered to use vision and thought, and we have never bothered to observe the obvious, that surgeons have to search for this hernia in each and every patient during surgery. That was a sackless hernia, which is often called a spermatic cord lipoma and shouldn't be called an inguinal hernia. Right? So that was case 2. That was pretty quick. All right. On to case 3. Now, this is more interesting. Now, an ultrasound of the right kidney. In this patient, it showed a cyst and a possible mural nodule here. We performed a Doppler, and on Doppler, there is some suspicion of flow internally. So to confirm, we did contrast-enhanced ultrasound. And on contrast-enhanced ultrasound, there is definite enhancement. So what do we think it is? It has to be a Bosniak 4 cystic renal mass, right? Okay. So here's the QR code of the CT of the same case. But you can follow along here. So CT was performed. I'm going to give you a couple of minutes to have a look. I see the comment that you can't see images. Are you able to see the video? Probably should see a video playing. It's kind of going through an axial and coronal going through both kidneys. Okay. So. All right, let's look at the first thing we notice is that it is not a single Bosniak cystic mass as we thought, but it's actually multiple solid renal masses. Like here, 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 just multiple. What we usually do now is to look at the differentials of bilateral multiple renal masses, right? And that is a huge list. So let's try to do a bit more digging. So from the patient records, we find that the patient has a known SLE. That's interesting. Now, does SLE cause any renal changes? It can result in renal failure, which this patient has, but there is no association with any renal masses. Aneurysms, maybe? They are more often seen in polyarteritis nodosa, and even then they are more central, and they do not present exophytically like this. Well, does any of the drugs used to treat SLE cause renal nodules? SLE is treated with steroids, which may result in immunosuppression and infection, but infection is highly unlikely without any stranding and fever, and it does not present with hyperenhancing nodules like this. So let us look at the other organs to see if we get any clues. There are these lesions in the spleen. Some are hyperenhancing, some are hypoenhancing. There is also this large lesion, and we found an old MRI from 10 years ago, and we see that the large one is a cyst, and the other smaller ones are actually hemangiomas. Spleen, we just have cysts and hemangiomas. Similarly, there are hyperenhancing nodules in the liver, and the old MRI, they're also T2 bright, and therefore they're also likely hemangiomas. So they were all incidental or red herrings. That doesn't help us. What do we do now? What? Well, the anonymous person strikes again. The little things are infinitely the most important. What little thing am I missing? Let's scrutinize again. You remember that the original renal cyst with a mural nodule on ultrasound? But this is how it appears on CT, as we can see here. It's not really a cystic mass, but it's incidentally a cyst with a solid lesion at the side of it. Notice that while, and that's the solid lesion at the side of it. Notice that while all the other solid lesions are rounded, this is flat. What does this mean? This means that the renal lesions are very soft. They are so soft that they are flattened just by a fluid filled cyst, because a fluid filled cyst cannot ever flatten a solid RCC. So that way we know that these lesions all have to be very soft. So what are some of the soft lesions of the kidney? Renal angiomyolipoma is known to be soft since it has fat. That is why it can have this angular interface sign or overflowing beer sign, because it can deform a little bit. But it's not soft enough to be compressed by a cyst. There is only one lesion soft enough to be compressed by a cyst. Do you need a clue? You've already encountered this in the same case, but in different organs. It can only be a hemangioma. And you must be wondering, can hemangiomas even occur in the kidney? Especially, can multiple hemangiomas occur in the kidney? In fact, they are known to occur with any end-stage renal disease of the kidney incidentally. And our patient had end-stage renal disease due to SLE. And in this context, they're called anastomosing hemangiomas, not because they arise in an anastomosis, but it's just because of something that the pathologists see under the microscope. This was a case of multiple anastomosing hemangiomas in this patient with end-stage renal disease due to SLE. So a lot of little clues came together perfectly to give us the diagnosis here. Just like that anonymous stranger had foretold. But that's neat. All right, let's go to case 4. That's the QR code. But let's have a look at the videos here. So there are 2 adnexal lesions. Have a look at these 2. One here, this one here. And the faces are mentioned. Wow. And this is an MRI of a young woman. All right. What do we find here? Now, the lesion on top, that is bright on T2. It's dark on every other face. So that's a cyst. All right? Done. Let's move to the other lesion at the bottom. And let's look at the top row now. It's intermediate on T2. It's a little bit bright on in face, and it is dark on a post face. So what does that mean? On in face T1, it has high signal. On a post face, there is signal drop. And we have learned that signal drop on a post face MRI means that it has to have fat, right? So an adnexal lesion, and this is actually arising from the ovary, with fat, it has to be a dermoid cyst, right? Ah, there he is. I was waiting for him to interrupt. What do you mean education never ends? Let's revise some of the facts with respect to basic MRI. Our body is made up of water. Signal from MRI is due to precession of protons, mainly water. However, the protons and fat, although they can precess at different frequencies, which means that at different time points, the protons from fat can either be in sync or out of sync with the protons in water. So let's say that there is a pixel here, which is composed only of water. It doesn't matter because all the protons will always be in sync. Similarly, look at this one. It has a pixel which only has fat. Once again, it doesn't matter because all the protons will always be in sync. But look at this one here. It has both water and fat. And these protons, some of them are in sync and some of them are out of sync at certain time points. And that is why they lose signal. So what do I mean by that is that consider that each and every rectangle is an MRI pixel, and there is a blob of macroscopic fat within any structure, let's say the liver, which is made up of water. All the pixels composed of water will be bright. All the pixels composed only of fat will also be bright. And only pixels with both water and fat, only the ones at the edges, they are the ones that will have a signal drop. So macroscopic fat will not drop in signal on a post-phase image. That is why the distinction of macroscopic and microscopic fat is important. Macroscopic fat, the fat is entirely made of fat and no water, so they don't drop in signal on a post-phase. However, what microscopic fat means is that the cells, which are mainly made up of water, contain lipid droplets within them. So if you have a blob of microscopic fat, it uniformly drops in signal because each pixel contains cells with water and tiny lipid droplets. Fat and water process at different frequencies and there is signal loss. So there is diffuse signal loss in microscopic fat, but not in macroscopic fat. In our patient, there is diffuse signal loss, which means it is microscopic fat. And dermoid cyst usually has macroscopic fat, and it was not the diagnosis here. So, as the anonymous stranger suggested, what we did was a bit more digging and educating ourselves further, and we find that a specific adnexal mass actually has microscopic fat, and it is something called steroid cell neoplasm. That's interesting. But what's the point of this? Is it just a zebra, an uncommon diagnosis, right? I mean, the lesion had to come out anyways, so they would have done surgery anyways, no matter what you called it, right? So the anonymous stranger, maybe you were wrong, because educating ourselves led us to nowhere because the outcome would have been exactly the same. What do you have to say for yourself now? Well, education never ends. It is a series of lessons with the greatest for the last. Is that your fancy way of saying I need to get educated more? Have a look at the CT here for the same patient. It was the case 4B. I'll give you a minute to have a look. But what did you see here? This, and look at this. There are these hyper-enhancing adrenal nodules here, and these were worked up and found to be pheochromocytomas. There is this left renal hyper-enhancing mass here, which is classic of clear cell RCC. You probably identified this as well. Then this. What am I showing in this image? Have a look. This is a spinal hemangioblastoma. And what is this syndrome with the constellation of RCC, pheochromocytoma, and spinal hemangioblastoma? You're right, it is von Hippel-Lindau syndrome. But how is this related to steroid cell tumor? Now, steroid cell tumor is a known association with VHL. In fact, in this patient, we first identified the steroid cell tumor, then suggested a CT, and that is what triggered the search and identification of the rest of the neoplasms and identification of VHL in this patient. So this was a case of ovarian steroid cell tumor, and educating ourselves and correctly identifying the steroid cell tumor triggered the search for VHL, resulting in identification of RCC and pheochromocytoma. You know what? The condescending stranger is actually starting to grow on me because so far his advice kind of makes sense. All right, let's move to case 5. Now, this was an elderly gentleman who had a thickened sigmoid colon. That was just due to diverticular disease. This was resected with end-to-end anastomosis. But after surgery, they suspected a leak. Okay? the QR code, but let's actually have a look at the image. So have a look at this. That's the colon. That's the anastomosis. That's the rectum with not oral contrast, rectal contrast in it. So we are trying to identify whether there is a leak or not. So this, is there a leak outside or is there not a leak? That's the question. That's the anastomosis. Here. Okay, perfect. Let's have a look. The question is very simple. Is there a leak? We have administered rectal contrast. Okay. This is the anastomosis here, right? Just superior to the anastomosis, this is the bowel lumen, and this is clearly extraluminal. And it appears bright, right? In fact, it appears as bright as the contrast within the bowel lumen, which means that the contrast should have leaked out. You know what? I don't want that anonymous stranger to come and find fault with me this time. So let me draw an ROI. In this extraluminal area, it's very similar to the attenuation in this area within the bowel lumen, even quantitatively. So this clearly means a leak, right? Damn. Well, there he is again. What now? Well, the skillful workman will have nothing but the tools which may help him in doing his work. But of these, he has a large assortment and all in the most perfect order. So you are saying I should have more weapons in my arsenal? What do I have? I even did quantitative. You know what? I'm going to follow one of your older advice and look more closely at the little things. Now, going back to the CT, when we look here, we find that it has this weird yellow circle around it. What is this circle? In fact, those of you who have looked at the case previously would have also seen additional series like this. What is this? Well, this is dual energy CT. So as per advice of a previous case, let's get educated about it. So whenever we talk about dual energy CT, they always talk about this photoelectric effect and K edge, and at the end of it all, this is how I exactly feel, right? So let's just try to simplify it. Most dual energy CT is based on water iodine 2 material decomposition. What it means is that they assume that each and every pixel is assumed to be made only of two materials, either water or iodine. So dual energy CT tries to split the image to construct two different images. One made of entirely water, the water only image is the virtual non-contrast or virtual unenhanced because it has no iodine in it, and the other, which is the iodine only image called the iodine map. We can find that the bone is present on both because dual energy does not know how to split calcium because it has a K edge between water and iodine. So it often presents it on both. Right. So instead of presenting the iodine only image like this, what they sometimes do is that they convert it into color and then they overlay it on the base image, resulting in a color map. So essentially, this is the virtual on contrast. This is the iodine color map. And let us pull up the routine image as well. And then let's just all zoom them up a little bit. Have a look now. This is the contrast within the rectal lumen. This is bright on the iodine map as expected. But now let's look at the area where we suspected a leak, which is this area. How does it look on the iodine map? There is absolutely no color within it, meaning that it does not have iodine, which means that the rectal contrast could not have leaked out. Have a look at the virtual non-contrast. It is bright on the non-contrast. It was just post-surgical hematoma. In fact, we actually see more extensive post-surgical hematoma in the rest of the pelvis here as well. The dual energy CT was able to identify the absence of iodine even when the attenuation measurement of hematoma adjacent to the anastomosis matched exactly that of the rectal contrast. So essentially, there was no leak. It was only a post-surgical hematoma. And as the stranger rightly pointed out, Having another weapon in the arsenal, dual energy CT, prevented us from misclassifying this leak based on conventional CT assessment, and it helped avoid another surgery in this elderly gentleman. Right? Here's another interesting one, and this was a young 38-year-old male. That's the QR code, but let's move to the images. Have a look at these images, especially look at the kidneys and the collecting system. I'll give you a couple of minutes again. All right. So this is an excretory phase with contrast in the collecting system. There are these linear, irregular appearing filling defects in the collecting system. No idea what they are at the moment. All right. The ureter, there is diffuse urothelial thickening and enhancement. It's very smooth and symmetrical. It does not look polypoidal like a urothelial neoplasm. The bladder is also thickened. But what is interesting is that the bladder also appears to be low volume, not just underdistended, it's contracted. I think something like a contracted gallbladder in chronic cholecystitis. You see that it's circular and it's just contracted. So overall, there is irregular linear filling defects in the collecting system, diffuse smooth urothelial thickening and enhancement, and a small volume thickened bladder. So what could this be? Absolutely no idea. Only thing I can think of is maybe something infected. What infection though? Given the linear appearance of filling defect, would it be fungal infection? Oh, you know what? I have a feeling that our anonymous stranger is going to have some objection to our thought process. Right on cue. There he is. It is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit facts. That's true because quite a few of you did think it was TB, but the appearance of the pelvic system is absolutely nothing in keeping with TB. So we try to twist facts to suit theories instead of theories to suit facts. Okay? But where can I go for more data? I looked through his medical records and there isn't anything useful there. Coincidentally, what happened is that the patient had an appointment for ultrasound the same day. And I thought, well, this could be a way to get more data. So I went and I met him in person. I introduced myself and we began chatting. And what I found was as follows. He's a young male who suffers from chronic debilitating pain all throughout his adult life. No organic cause was ever found. The working diagnosis was reflex sympathetic dystrophy. Various treatments had been tried, including high dose ketamine and opioids. And he says that they are the only ones which help him with his disease. And after a bit of chatting, he confided that he had been abusing them for the last 12 years. The last few years, he also had multiple episodes of hematuria and flank pain. And here is the kicker. These episodes of hematuria and flank pain correspond with the times of excessive abuse of ketamine and opioids. Bingo. So immediately I knew that the culprit had to be one of them. And digging through the literature, there was no association of opioids with urothelial lesions. But ketamine, I found that ketamine is associated with something called ketamine induced uropathy. The presumed hypothesis is that ketamine metabolites are excreted in the kidney. They have a gelatinous consistency seen as irregular filling defects. They are directly toxic to the urothelium, resulting in urothelial denudation seen as urothelial thickening, and repeated episodes of injury and scarring in the bladder results in a small volume bladder. So, that was a patient with ketamine induced uropathy. The diagnosis was only possible only because we went digging for data and managed to track down the patient to have a chat. All right, on to case number 7. You know the drill now. Okay, so what do we see here? Have a look for a couple of minutes. Just have a look mainly at the peritoneum, left side, these areas. All right, so what we find is numerous peritoneal nodules, mostly distributed on the left side. Looking carefully, we find that most of these are very hypoattenuating. The other thing we find is that there is this cystic appearing mass in the left adnexal region. So, what do we think here? Yeah, peritoneal metastasis, pseudomyxoma. So, the peritoneal metastasis are likely peritoneal carcinomatosis, which have a predilection to the left side. And given the hypoattenuating appearance, the left adnexal cystic mass, it has to be a mucinous tumor with mucinous peritoneal carcinomatosis, right? In fact, this is how it was reported, and it was referred to the peritoneal multidisciplinary cancer clinic in my hospital for consideration for HIPEC, for like cytoreductive surgery and HIPEC. And it was actually sent to me for a second opinion. Well, I agree with you, stranger. Starting to grow on me now. Data, data, data. I can't make bricks without clay. So I decided to dig in to find more data in the patient medical records. She's a middle aged woman. All tumor markers were negative. She was completely asymptomatic. The clinical record was very extensive, and I had to go through 25 years worth of numerous clinical notes, and I did not find anything relevant, except there was one brief mention of percutaneous drainage of an abdominal cyst, and no further details of where the cyst was or why. That's interesting. Also, there was mention of one prior MRI in 2000, but the images were not available in my PACS system. So what do we do now? You know what? I'm not giving up that easily. So I called up my PACS department and inquiring what happened to those images. They were surprised because no one had ever asked them for imaging from 23 years ago. They said that, oh, they're all stored off-site server. They have to be manually retrieved. It is a hassle. Hassle? I reminded them. A patient's diagnosis is on the line. They weren't happy. They told me it'll take a couple of weeks or even a month. I persisted. I kept calling them every other day. Finally, after a couple of weeks, I got the images I wanted. And here it is. Are you ready? This is the image of this MRI of the same patient from 23, 24 years ago. See a comment that it doesn't look like this. That's exactly how mucinous peritoneal carcinomatosis would look like as well. However, in this case, just by having these images, we find that there is extensive cystic changes all through the abdomen, all through the peritoneal cavity. Look how extensive it is. It's insinuating between the structures. This was actually peritoneal lymphangiomatosis. This is benign. Over time, over 25 years, it has slowly decreased and spontaneously regressed over time. Now, it has been rediscovered when it has become much smaller when it mimicked peritoneal carcinomatosis. On CT, it was hypodense, but that was not because of mucinous origin, but because it was regressed lymphangiomas. So this was a spontaneous regression of peritoneal lymphangiomatosis, which now mimicked peritoneal carcinomatosis. Diligent digging for more data prevented the patient from having unnecessary invasive management. And the stranger was right again. All right, this is the final case, case number 8. So there's a case 8A and 8B, which is both MRI. So here's the CT. I'll give you a couple of minutes to have a look. All right, what are the main findings here? Right, there's soft tissue seen in bilateral paravertebral location in the mediastinum. And it appears to be enhancing on the CT. I mean, although without a non-contrast CT, we can't be sure, but it's reasonable to assume that it is enhancing. Now, moving down, we find that the soft tissue is extending into the abdomen, into the retroperitoneum. More inferiorly, it is also extending around the kidney. Right, around the kidney, there is bilateral rind-like soft tissue in the perinephric space around both kidneys. What do you think that is? Well, I know what many of you are thinking. Bilateral rind-like soft tissue around the kidney, especially in an interesting case session. Well, it has to be Erdheim-Chester disease, right? I mean, I see one of that in the comments. Well, I'm disappointed. Didn't we just learn that it's a cardinal sin to guess before we have all the information? Maybe you don't follow the advice of an anonymous stranger, but let me tell you that a diagnosis of Erdheim-Chester in real life is kind of like the diagnosis of lupus in House MD series, in that, well, it's never lupus. All right. The coronal shows the entire extent of the soft tissue in the chest and abdomen. So what could it be? It is a sheet-like infiltrative soft tissue involving multiple compartments and appears to be soft in that even blood vessels within it don't seem to be narrow. So the logical diagnosis, next diagnosis, has to be lymphoma, right? And I see that in the comments as well. That is exactly what we thought until we saw the MRI. Now, on MRI, this is what we find. What's wrong with the MRI? This is the MRI at the level of the paravertebral soft tissue chest. I'll give you a couple of seconds to have a look at it. This is the T2. This is the in face, and this is the opposed face, right? These are the images of the abdomen at the level of the retroperitoneal soft tissue. That's the T2, that's the in face, and that's the opposed face. Once again, I'm going to give you a couple of seconds. What do we notice here? Soft tissue here is seen on T2. On T1 in face, it is bright, but on T1 opposed face, there is drop of signal. Now, this is surprising. And we just learned that macroscopic fat does not show signal drop. For example, the subcutaneous tissue is macroscopic fat. It does not show a signal drop and is bright. Signal drop is only seen with microscopic fat. And we know for a fact that lymphoma does not have microscopic fat. So that can't be the diagnosis. So what could it be? Yeah, quite a lot of you have said hematopoietic tissue. So what entity presents as bilateral paravertebral retroperitoneal soft tissue and have microscopic fat or diffuse signal drop? Extramedullary hematopoiesis. Quite a lot of you mentioned that. But are we sure that it's extramedullary hematopoiesis? Because remember what that anonymous stranger taught us. We need more data. First of all, we need to know if this patient has a hematological disorder or any other systemic disorder that can result in extramedullary hematopoiesis. So I digged into the data, I searched for it, and you know what I found? I found nothing. We found absolutely nothing. But by digging through the history, we found something else. What we found is that the patient had a history of characteristic episodic palpitations and hypertension. Episodic palpitation and hypertension, that is characteristic of pheochromocytoma. We looked at the CT again. Buried within the soft tissue, we did find a nodular mass in the supraadrenal location. suprarenal location in the adrenal, in the expected location of the adrenal. In fact, it was actually easier to identify on the MRI. And it's very characteristic. If you look at the T2 here, we find that it's very bright, as bright as a light bulb. And on the T1 in phase and a post phase, there is no signal drop, which means there's no microscopic fat within this adrenal lesion. Microscopic fat in an adrenal nodule, as you know, is only seen with adenoma. It's not seen with pheochromocytoma. So all these signs point that this is a pheochromocytoma. That's amazing. Except that still doesn't explain all the soft tissue in the chest and abdomen with microscopic fat. Could that be a coexistent extramedullary hematopoiesis? Now, pheochromocytoma actually has no association with extramedullary hematopoiesis. And we also found nothing in the history which is supporting extramedullary hematopoiesis. Besides, let's remember Occam's razor, which suggests that entities should not be multiplied beyond necessity. Basically, it means that do not entertain multiple diagnoses when a single diagnosis would suffice. So what else could it be? Could pheochromocytoma or its secretions be somehow causing changes in the surrounding fat? Well, I don't know. I don't even know if such a thing can occur. But all I know is that I've excluded everything else. The anonymous stranger strikes again. When you have eliminated the impossible, whatever remains, however improbable, must be the truth. Very interesting. So I go to Dr. Google and I type in pheochromocytoma, changes in perirenal fat. And the first result is a case report from radiology. Eagerly I click it. The title is Adrenal Pheochromocytoma with Perirenal Brown Fat Stimulation. I scroll down to the images, and the images are almost exactly a carbon copy of ours. An adrenal nodule on the right side, in the setting of pheochromocytoma, with extensive perinephric retroperitoneal soft tissue. Apparently, adrenergic stimulation from epinephrine in the surrounding fat from a pheochromocytoma leads to activation and transdifferentiation of mature adipocyte, mature fat to brown fat, which looks exactly like this. That was a case of a pheochromocytoma induced brown fat transdifferentiation. It was once again the wisdom of the anonymous stranger that led us to this. But wait a minute, what did he actually say? When you have eliminated the impossible, whatever remains, however improbable, must be the truth. Wait a minute, I have heard this somewhere before. I have read this somewhere before. In fact, every single quote of wisdom from the stranger, I have read every single one of them somewhere before. Finally, the realization dawned on me. I know who he is now. It's just elementary. It's Sherlock Holmes. Now it makes sense. A lot of things from this session as well as to why it was titled Cases from the Archives, how we are dealing with clues and red herrings, culprits and suspects, how we are conducting investigations, how we are digging into histories, how we had a bunch of unsolved cases and we successfully cracked every single one of them. The similarities and parallels between our worlds, the world of the detective and the world of the radiologist, is striking. Now it makes so much sense as to why Sherlock bothered to provide us his wisdom from his cases and why it was amazingly applicable to our cases. Because what detectives do and what radiologists do are remarkably similar. We asked ChatGPT to define what a radiologist was and it wasn't very helpful. But then I asked, what do radiologists do? And ChatGPT replied, radiologists detect and deduce, the very two verbs that sum up the essence of a detective. Doesn't that give you goosebumps? Doesn't that change your outlook and make you approach radiology with a new spark of passion? You know what? It would really be a shame if we don't put all of Sherlock's great advice to test. You know what? Let's do one last case and see how well we can follow Sherlock's advice. The game is on. Case number 9. Let's look at the images. Wait a minute. What has Sherlock taught us? We need to collect as much data as possible, right? So, this was a young female who was pregnant, who was presenting with acute abdominal pain, no features of bowel obstruction. Lipase was very elevated. So, I guess the concern is acute pancreatitis. And we did inform the clinician that there is no indication of imaging to confirm the diagnosis of pancreatitis. But the clinician was very worried as the patient was much sicker than we had expected and had a gut feeling that things were very wrong, although he could not pinpoint anything more. So, once again, I'll give you a couple of minutes to have a look. Case number 9 on collecting minds case set I sent you. Well, what do we find here? First off, it's a non-contrast CT as the patient was very worried and refused intravenous contrast because it was a pregnant patient. But she did have oral contrast. Secondly, it's an extremely low dose CT with dose lower than renal colic CT. Again, the radiation risk in the third trimester is extremely low, but the patient was super worried and we had to accommodate her concern. But most importantly, the pancreas appears normal. There is no surrounding stranding, no collections. It could still be mild interstitial pancreatitis, which is often imaging occult, but it does not fit with the description that the patient is very sick. Is there something else going on? Let's remember Sherlock's advice on the little things being important. Let's scrutinize again. What are these? These linear hyperdense structures close to the gastroesophageal junction. That's not the oral contrast. It's outside the bowel and linear, very hyperdense, and looks like sutures. So we call the clinician up to check a prior surgical history, and then we are informed that the patient has a Roux-en-Y gastric bypass a few years ago. That changes everything. Now, as per Sherlock's dictum, it's time for us to educate ourselves. Roux-en-Y gastric bypass is a type of bariatric surgery. In this, the stomach is sectioned here. There is a small gastric pouch, which is then anastomosed with the jejunal limb. The food goes through the limb here, which is called the alimentary limb. And this alimentary limb is separated from this part of the stomach. So this part is called the excluded part of the stomach because it is separated. And this limb is the biliary limb. And one of the complications from this surgery is internal hernia. And despite many surgical improvements, it continues to occur. And in fact, internal hernia is one of the major considerations in any patient with Roux-en-Y presenting with abdominal pain. Not bowel obstruction, even they present with just abdominal pain, that should be the number one concern, right? So if you look at the literature, you will find that there are many signs of internal hernia which have been described. And even more signs have been described. Then if you're like me, you'll be like, you know what, let me just look at the images and more images. And finally, you're left totally confused. So to address this, a study was done by the Ottawa group when I was there. And they looked at all these signs. And only 2 signs, swirl sign and the SMV beaking sign, had a decent sensitivity and specificity and inter-observer agreement. So that is pretty much all you need to do. All the other signs were not very useful. So here you find that there is a mesenteric swirl here. Okay. Personally, I find that the SMV beaking is easy to identify. The SMV abruptly narrows here, as you can see. And it is actually better seen on coronal, in which there is sudden abrupt narrowing of the SMV here. But what to do when the patient is pregnant? Because internal hernia is common in pregnancy due to the enlarged uterus, pushing the bowel through the Peterson defect. Sherlock advises us to have more weapons in our arsenal. Easy. You can just do a non-contrast MRI here. The SMV beaking is usually easy to identify. But in our patient, unfortunately, MRI was not an option in the emergency setting because logistics was precluding. So what do we do then? Let's have a look to see if you're able to appreciate the SMV beaking or the mesenteric swirl. The lack of contrast, even the SMV is very difficult to identify, let alone say if there is beaking. Even the presence of mesenteric swirl cannot be ascertained due to the pregnant uterus. So what do we do now? But then again, even if we could confirm that it is internal hernia, how does it explain the elevated lipase level? Because remember, the clinical history is elevated lipase and there was concern of pancreatitis, and this makes no sense. Sherlock advised us about observing, using vision and thought, not just seeing. Having one more look, we know that the patient has had oral contrast. But what is this fluid filled structure which we kind of see here? This is actually the excluded portion of the stomach. And if you remember, I told you that the excluded portion of stomach should not have any content and should be collapsed. But here it is fluid filled and distended. How did this happen? Let's think. The only way this can happen is if there is an obstruction in this part, that is the biliary limb. An obstruction here results in accumulation of fluid, the biliary and the pancreatic fluid, within this portion, which can then continue to distend, and distension produces tension within the pancreatic ductal system, resulting in a presentation with increased lipase similar to pancreatitis. But because this is not connected to the alimentary lymph, there are no clinical features of obstruction like vomiting and presence only with abdominal pain. But more importantly, because this end is closed here proximally, continued distension can be life-threatening as it is basically a closed loop obstruction here. Now, this is a wild theory, but is the only one that accounts for all the clinical presentation and imaging findings. We know, Sherlock, when you have eliminated the impossible, whatever remains, however improbable, must be the truth. We called the surgeon with this theory. The patient was taken to surgery immediately, and they confirmed a biliary limb obstruction, which was in fact resulting from an internal hernia. So, this was a patient with gastric bypass, associated internal hernia, which was precipitated by an enlarging uterus of pregnancy, which resulted in a biliary limb obstruction, therefore presenting with pancreatitis. It could have been life-threatening, but was operated on time due to our diligence, and the patient did well. That was exhilarating and life-saving. You know, Sherlock, as you all know, is widely regarded as the GOAT, the greatest of all time. There were many detectives before him. There were countless after him, but none could reach his heights. What made him so extraordinary? What separates the ordinary from the extraordinary? Because whatever it is, it could be applied to us, the radiologists, the detectives of medicine. Is it his unsurpassed powers of observation or his amazing skills of deduction? Maybe that's what makes extraordinary radiologists. Extraordinary skills of observation and deduction. Probably. But wait, that's not it. That can't be it. Why not? Because Sherlock says so. In this conversation with his trusted sidekick Watson, they were discussing his brother, Mycroft Holmes. So, Sherlock says that Mycroft, who is Sherlock's brother, has better powers of observation than him. And Watson is confused. And Sherlock says, I said he was my superior, like Mycroft is Sherlock's superior in observation and deduction. But if the art of the detective began and ended in reasoning from an armchair, my brother would be the greatest criminal agent that ever lived, the greatest detective. But he has no ambition or no energy. He would not even go out of his way to verify his own solutions and would rather be considered wrong than take the trouble to prove himself right. He was incapable of working out the finer points or practical points which must be gone into before a case would be presented to the jury. Let me read that again. Sherlock says that Mycroft is superior in observation and deduction, but he's not the better detective. Because if the art of the detective just began and ended in an armchair, his brother would be the greatest. But it doesn't. He doesn't have the energy. He doesn't have the ambition. What he means by this is you could be the greatest at observation and deduction, but you can't be a detective. Or in our case, you can't be a radiologist if you're lazy. If you sit in an armchair and give excuses and complain that, oh, the clinician has not provided me with all the information. He didn't provide me history, or the history is just completely useless. And if you keep giving excuses like this, you're not going to be the greatest radiologist of all time. So, what makes someone extraordinary? In Sherlock's own words, genius is an infinite capacity for taking pains. It's not just observation and reasoning, it is how willing we are to do a little bit extra. Now, let's be honest. The point of showing you all these cases here today was not just to show you a bunch of unusual diagnoses or a bunch of zebras, if you will. Yes, it was to help improve how we detect and deduce, but also how we had to go the extra mile to reach the diagnosis in most cases. In the first patient with lung cancer, not just see, but observe and identify the femoral neck metastasis and the venous thrombosis. In the patient with sliding hernia, how observation and reasoning is important even in little things like inguinal hernia, which we take for granted. In the patient with anastomosing hemangiomas of kidney, how we had to be extra careful and observe the little things, the fact that the cyst was compressing the hemangioma. In a patient with steroid cell neoplasm, how we had to get educated on macroscopic versus microscopic fat and go the extra mile and identify the tiny spinal hemangioblastoma to suggest to the clinical team to test for VHL or von Hippel-Lindau syndrome. In the patient with suspected leak, how extra weapons in the arsenal, dual energy CT, can be helpful. In patients with in the patient with ketamine-induced neuropathy, how carrying a little bit extra, making the effort to try and meet the patient and talking to the patient led to the diagnosis. In the patient with peritoneal lymphangiomatosis, how taking the extra effort to dig into history and prior exams and how calling the PACS team to get that old seat MRI from 2000 was useful. In the patient with pheochromocytoma and internal hernia, it was a summary of all we learned and a little bit extra. That extra care, that extra effort, going that extra mile, that little bit extra is what makes an ordinary career into extraordinary. You might tell me, how do you expect me to do a little bit extra all the time? I barely have enough time as it is. Well, if there is one thing I've learned from the greats, going that extra mile is possible only when somebody truly cares. Care for the patient who live and breathe behind every image we look at. Care for their families who depend on them. Care that the world would be a better place only if we do our absolutely best. Maybe you don't care for that. Just care for your own legacy, our own bragging rights, our own ego. Care for the right to be called the greatest radiologist of all time. The next time on my flight back, and somebody asks me what I do, I'm telling them I am a radiologist. We are the detectives of medicine. And when they say, oh, you must be proud, I'll go, you're absolutely right, I am. Because I always go that extra mile because I care. Thank you.
Thank you so much, sir, for that awesome presentation. All of us are speechless, and I'm sure it's one of the best of the 700 webinars that we have had. I'm happy to share we had close to 450 attendees today, and you can see the love that you're getting in the chat box, and people want you to go on and have more sessions on this forum in future as well. So I'm already booking you for future sessions, sir. It was lovely to have you on this platform and creating an insight that how we can think and help save lives. That's what we radiologists and as doctors should be doing. There are a couple of questions in the Q&A. It's more of compliments and few questions actually. Can you please take them as you feel convenient?
Oh, definitely. Thank you very much. Thanks for staying here on a Sunday evening to listen to all of this. Before I go there, I'll just kind of quickly plug in. And in case you weren't aware, we have been doing a podcast, audio, and then now more recently we've moved to YouTube as well. But at Imaging Toronto, that's kind of where you can find us almost everywhere, like on Twitter or X as it is called now, LinkedIn, YouTube, where we actually have video versions of these podcasts as well as other videos we're coming in. None of these are particularly educational, but it's kind of a behind the scenes of how to think. Like there was Kieran Murphy, who's also an inventor. So it's just a behind the scenes of radiology. So if you're interested in kind of looking at that, but personally, if you want to reach out to me, this is my Twitter as well as my email here, in case any of you are interested. So in touch base with that, and I'm happy to jump into the Q&A part of it. Can you please repeat about the sackless hernia again? So basically, the point is that anytime there's fat in the inguinal canal, we just say, oh, there's fat containing inguinal hernia. When you say inguinal hernia, it generally means that the fat is coming from the peritoneal cavity. Omental fat is coming through the inguinal canal. But in the case I showed you, and quite often, it's not the inguinal hernia, it's actually fat from the retroperitoneum, which is sliding behind the inguinal openings. So this distinction is important. Previously, when they're doing open surgery, they would cut out everything, so it wasn't that important. But nowadays, when they're doing these laparoscopic surgeries, this distinction is important because they go in and they close that inguinal ring, but the hernia is not actually occurring through the inguinal ring; it's actually behind. It's a retroperitoneal hernia. The problem is that there's no good terminology for this. Um, Even if you call it a sackless hernia, they wouldn't understand what it is. They kind of understand only spermatic cord lipoma, which is actually clearly a misnomer, but that's kind of what they understand. So you just need to alert them that this is not just an inguinal, because it has happened with us, in which inside the OR, the surgeon is, and he's like, I opened it up and I'm not able to find any hernia there. Then we look at the image and we're like, oh, it's never an inguinal hernia. It's actually like a retroperitoneal sliding fat. Yeah. Do you mean if you found retroperitoneal fat herniating within the hernia, it will be called lipoma of the cord, right? You are right. That's what the terminology has been, but it's obviously wrong. The nomenclature or the semantics is just totally wrong. But it has not been described in any other better way anywhere else. So even in the most recent guidelines on hernia, the only reference is regarding the lipoma of the spermatic cord. So just to make sure that you and your surgeons are talking the same language, you can keep using the term. But at some point of time, somebody has to come and change these terms. What are the bilateral breast cysts in case 3? Sure, I don't think it was relevant to the case. And even it was, I probably wouldn't know that. I've been doing abdomen alone for quite a long time now. So I wouldn't be very useful in the breast. Thank you very much for the compliments. What's the cause of misty mesentery and jejunal thickening in case 2? Well, a lot of times what you call jejunal thickening is probably not. Jejunum can appear thickened normally, otherwise. I don't think it was anything significant in that case. Misty mesentery is once again completely pointless to look at. It's usually just benign mesenteric panniculitis. There's no point even mentioning those things in the report. One of the biggest gripes I have is how much junk we put in the report. A misty mesentery, it's not going to be anything. Like, what do you want the clinician to do? Do you want them to do a repeat CT? If so, say that I'm worried about it, do a repeat CT. But just saying benign findings in a radiology report, it's just going to cause patients to be like, oh my God, what do I have? Without actually improving their care at all. So misty mesentery by itself doesn't really mean anything. If it is associated with a large amount of lymphadenopathy, you need to think about lymphoma. But in that case, it was just all completely benign. Thank you very much. I find a lot of compliments here. How do we detect the gastric distension part? So the last case is very straightforward, but however straightforward it is, we realize it is straightforward after we make grave mistakes. So one of my teachers in Ottawa, they taught me this. When there is a Roux-en-Y gastric bypass, the stomach is excluded from the food. The stomach should always be empty in the setting of a Roux-en-Y gastric bypass. What happened is that there was almost exactly the same patient in the ICU, but not pregnant at that time. But nobody identified that the stomach was distended. And after a few days later, the patient died. And in retrospect, after like an M&M and stuff like that, they realized that, oh my God, that was actually beryllium obstruction, resulting in like a closed loop, which just kind of completely burst that stomach. So in Roux-en-Y gastric bypass, we are always looking for that SMV kink to identify internal hernias. But another thing we should always be looking for is this: is there a lot of fluid in the stomach? If there's a lot of fluid in the stomach, it can only mean two things. One is that there can be a gastrogastric fistula, that is from the gastric pouch into the extruded portion of the stomach. There is a fistula, which means that the actual efficacy of the Roux-en-Y gastric bypass is not going to be there because the food is not going through the stomach, or it means that there is a biliary limb obstruction. Now, usually with the clinical presentation, it'll be straightforward. A patient with biliary limb obstruction will be very sick. But if the patient's not sick and you don't know where the contrast is coming from, we can do a fluoroscopy study. So we can identify whether the contrast is going directly from the gastric pouch into the extruded portion, or if it's actually coming all the way around the anastomosis and then kind of going. What is the stomach antral lesion in case 3? Stomach in the first case. What was the first case? I don't think there was anything specifically in the stomach in the first case or in the third case. I don't think that there was anything significant in either. Can you please repeat internal hernia rising lipase levels? So, internal hernia does not cause elevation of lipase. Okay? But in a Roux-en-Y gastric bypass, when the biliary limb is obstructed, that biliary limb is a closed loop. It's not specific for Roux-en-Y gastric bypass. Even some form of Billroth will have that duodenal stump, right? So any surgery with a duodenal, like blind ending stump or like a biliary limb like that, if you obstruct the biliary limb more distally, all the pancreatic and biliary secretions inside that limb will continue to distend that limb. Now the whole thing is under tension. That will mean that the pancreatic duct, which is connected to the biliary limb, will also be under tension. Because it's all under tension, it'll rise the lipase levels because it'll essentially have a picture like pancreatitis. Can hematoma versus leak be detected by doing plain scan without contrast and then later rectal contrast? That is absolutely correct. That is the better way to do scans in general. So in patients where you're suspecting a leak, it's always a good idea to do a non-contrast first, then give rectal contrast, and then do a scan. But quite often we miss that. And again, I'm not saying that you don't do it for radiation doses. Radiation dose from CT is extremely low, and it's usually not a huge concern at all. And especially in cases like these, you shouldn't try to skip out that. But often what happens is that either the technologist, like either the institutional protocol is that you just direct contrast and do it. It's actually more complex when you have to do it with oral contrast, right? So if the patient you're looking for a leak, then you're doing a non-contrast, then you're asking the patient to go out and drink for like 30 minutes and then come back on the scanner. It's very cumbersome. So not a lot of places have the time and bandwidth to do that non-contrast often. And secondly, in that case, you can argue that, oh, why didn't we bring the patient back and do a non-contrast? We were not even suspecting that it's not a leak because attenuation measurements did look like a leak. I would have called it a leak, except that dual energy was available. And when I look at it, I'm like, oh my God, this is actually not a leak. So if there was no dual energy and there was no anything, I would have just called it a leak and I would have been dead wrong about it. Kindly explain about anastomosing hemangioma. Now, anastomosing hemangioma is just a fancy way of calling certain types of hemangiomas. It's anastomosing, just on the pathology slide, they see something. That's it. For all intents and purposes, you can just assume that it's a hemangioma. However, these do not necessarily behave exactly the same way you expect from liver hemangioma. So in liver, you know that there'll be this peripheral nodular discontinuous enhancement with progressive centripetal fill-in, right? These hemangiomas do not necessarily behave like that. So this anastomosing hemangioma group was primarily described in the genitourinary tract. It can occur anywhere in the retroperitoneum. Usually it is single, but what has been recently found is that a lot of patients with this end-stage renal disease, you're actually finding these anastomosing hemangiomas. Kind of interesting because previously when there is GFR is less than 30, you almost would never do a contrast enhanced CT. If you don't do a contrast enhanced CT, you're never going to find it. So you just call it normal and just go on. But these days, especially when the patient's having a dialysis and stuff, you still inject contrast. So we're detecting these more these days. The problem is be very careful. Patients with end-stage renal disease are also at a higher risk of many types of malignancies. They can have like clear cell papillary, clear cell papillary. There's like a whole bunch of, there's an acquired cystic disease associated RCC. There's a whole bunch of RCCs which can occur in that setting. So just because you saw a weird case here, do not apply it directly there. The whole point of this lecture was to try and show that you need to put in extra effort and cover all your bases. So, for example, there was a case of that peritoneal lymphangiomatosis, which I showed you. If you see a CT like that again, and immediately if you call it peritoneal lymphangiomatosis, you're going to be wrong 9 times out of 10. Because that is classically how a mucinous ovarian lesion or a mucinous lesion in the colon with metastasis to ovary and peritoneal carcinomatosis, that's exactly how it looked like. The only point I was trying to make is that when there is a prior, always go into prior, dig into clinical history. Patient was asymptomatic, then something didn't add up. Look, dig into clinical history. There was some history of drainage of cyst. Okay, what the hell is that? And then dig into the prior, and then you're like, oh my god, this has to be peritoneal lymphangiomatosis. So do not take things from an interesting case session and apply it to your next case. The entire point of it is to show you how you need to put in extra effort to diagnose all these cases. In that anastomosing hemangioma case, what we learned is that patients with end-stage renal disease can often have multiple anastomosing hemangiomas, especially when the ones with who develop at a little bit younger age group. It's been known those are very benign, can kind of leave it alone. But the problem is often you can't differentiate it from an RCCF, especially if it's single. So you might need a biopsy to kind of prove it. But again, like that distinction is very tricky to make. In this case, we were able to make that because there was a cyst which was compressing an RCC. There's a finer nuance to this. That was a hyper-enhancing nodule. The only differential for a hyper-enhancing nodule would be a clear cell RCC, which is usually a hard nodule. So cyst cannot compress on a clear cell RCC. However, papillary RCCs are a little bit softer. Sometimes cyst can compress on a papillary RCC, but in that case, it was hyper-enhancing, and papillary RCCs are not hyper-enhancing. So there was like a little bit more layering to that, and that's kind of what I wanted to point out. So, anyways, like end-stage renal disease can cause hemangiomas in the kidney. That's called anastomosing.
Thank you so much.
That's pretty much it, right? Yep.
And it was one of its kind. We were really grateful that you took this up session and with us on this Sunday evening. And I'm glad that I had exchanged it from the 30th March webinar, 30th June webinar, so that even I could attend it. It was lovely to have you on this forum, and as there are plenty of requests in the chat, we would love to have you with another interesting talk in the future as well. Hope you have a great Sunday ahead.